dear colleagues. I would be discussing upon the prevalence, risk factor, pattern, and the treatment outcome of severe ROP in Jharkhand. As we all know, ROP is a disease of retinal vascular and capillary proliferation affecting the premature infant who undergo the oxygen therapy. So, it was a retrospective observational study done at the tertiary care center in the Jharkhand. The study evaluated the incidence, risk factor, and severity of ROP in relation to the gestational age, birth weight, and the treatment modalities. Where our inclusion criteria was as per the neonatal guidelines of India: birth weight less than 2 kg, gestational age less than 34 weeks, gestational age between 34 to 36 weeks if exposed to risk factor like prolonged supplementary oxygen, respiratory distress, or blood transfusion. The ICROP 3 was used to record the stage, location, zones, and signs of the plus disease. We have our follow up first at between the 4 to 6 weeks of life, and the final follow up was till the retinal full vascularization and the maximum stage of ROP. The data was analyzed using the SPSS software. So our results were we had a total of 646 infants. Mean gestational age was 32 weeks. Mean birth weight was 1.6 kg. Mean gestational age at the time of ROP examination was 37 weeks. We had more of C-section deliveries, and we had one more correlation, that was the 417 babies were born by the ART, that is the IVF technology. So coming on to the incidence part, 49% babies had no ROP, 21 babies had zone 2 stage 3 plus disease that needed ROP laser, and 15% baby had AP ROP that was treated with injection anti-VEGF followed by ROP laser, and 14% baby had zone 3 stage 1 no plus that were just kept on the follow-up observation. They showed spontaneous regression in due course of time. 1% baby had stage 5 ROP that needed ROP surgery. Coming on to our treatment outcome, among the stage 5 ROP, one baby showed regression with the retina on in the consecutive follow-up. Zone 2 stage 3, those needed ROP laser all show regression. AP ROP, only one needed augmented laser, and the spontaneous regression group. So coming on to the result part, the risk factor associated with ROP were lower birth weight, gestational age, and our respiratory distress syndrome. Discussion part, ROP is a serious morbidity of prematurity whose incidence and severity increases with the decrease in gestational age and birth weight. Our finding is not comparable to those from the other study. Being a tertiary care center, we had more of high-risk babies, more IVF babies. So we had a higher incidence of ROP, especially the severe ROP. As we all know that birth weight, gestational age, and respiratory distress are well-known risk factor for the ROP. In this study, a lower birth weight, shorter gestational age RDS were independent risk factors for the severe ROP in infants. So we can conclude that high incidence of infants with the ROP in our study emphasize the need for aggressive measures for prevention and control of the disease, the safe implementation of oxygen therapy with appropriate monitoring, better antenatal and neonatal care, meticulous attention to hygienic processes, and control of sepsis may reduce the prevalence of ROP. Early referral, adequate treatment, and regular follow-up necessary. These were my references. Thank you, AIOS, for this opportunity.
What was the follow-up in APROP with intravitreal anti-VEGF? How long was the follow-up?
Sir, first follow-up after the anti-VEGF, we did it after 1 week of the anti-VEGF, and then we followed up the child, like after 2 weeks. If the child show improvement, then we follow up him again. But when we show that there is a closer loops or we don't show any improvement in the ROP, then we go ahead with the laser. And we had a final follow-up at least at 52 weeks, and the consecutive follow-up at 3 months of gestation, 3 months of birth, and next follow-up at 6 months.
I hope all the presenters are here and their program is loaded because it's a very tight back-to-back program.
Sir, we had more of severe ROPs in IVF babies, especially that we have another paper. We have presented it yesterday only. Ki IVF babies has more of a severe ROP compared with the normal delivery, those who born by the natural conception route, and even in the that also the aggressive ROP, zone half ROP, all these are severe ROP are more in IVF babies.
So exactly what is it? Exactly what is it?
You are the key person opening. Prakash Marathi will be the one who will be open the.
Very good morning. Very good morning. My name is Dr. Neeraj Sani and I'm presenting Retinal toric marker.
Yes, sir. We did the comparison. We had our comparison at every gestation age, like 20 weeks, 24 weeks, and even we have seen that those born after 34 weeks of gestational age, those born by the IVF, they have more of ROP, that to severe ROP, compared with the normal conception, those born by after 34 weeks. Even more than 2.5 kg are showing incidence of ROP in the IVF group compared with the normal conception. So, thank you, sir.
So Dr. the hand marker invariably give us a picture like this, which is completely off the axis. So we use accurate, stable, and easily used toric marker. We took inspiration from the Goldman's affirmation chronometer.
Good morning, everyone. Good morning, honorable judges. So I'm Dr. Raghunathan, Vitreo Retinal Fellow from India. And the title of my presentation is Uses of Multicolor Imaging versus Color Contrast Photography in Macular Telangiectasia Type 2. I have no financial disclosures. So as we all know, macular telangiectasia can be identified by blue reflectance imaging, which is a rapid and a non-invasive diagnostic tool that makes use of confocal scanning laser ophthalmoscopy. However, the gold standard to diagnose these signature lesions are color contrast photography. The aim and objective of my study is to describe the various lesions of macular telangiectasia type 2 by using multicolor imaging and to validate them with corresponding signature lesions in color contrast photography. So our study included all patients who had macular telangiectasia type 2 who were all the patients where the diagnosis of all patients were confirmed using reflectance imaging, autofluorescence as well as OCT. So those patients who had coexisting macular pathology were excluded from the study, and of course those patients who had media opacity and poor image qualities were also excluded. So all of the patients underwent color contrast photography and multicolor imaging, and these images were viewed using Heidelberg viewer, and color contrast photographs were simultaneously viewed in the same computer with higher screen settings. All the images were looked for, and various lesions of macular telangiectasia were observed. So all patients, we also observed macular telangiectasia ellipsoid area, which is the maximum horizontal and vertical diameter of the hyporeflectance or isoreflectance in various imaging, and all the images were observed by 2 retina specialists. So these were the various lesions and results. So 48 eyes of 24 patients were included in our study. So 2 patients had poor image quality, and the mean age of presentation was 53 years. So among the various multimodal imaging, macular telangiectasia lesions like yellow crystals and graying were well appreciated in multicolor imaging, while the rest of the pigmented lesions were observed equally in both the imaging. Moving on to the multicolor imaging, the yellow crystals and right angled venule were better observed in green reflectance imaging, while the graying of macula was better appreciated in blue reflectance imaging. With color contrast photography as a comparator, the sensitivity and specificity of MCI to detect macular telangiectatic lesions were more than 95%. However, with MCI as a comparator, the sensitivity and specificity of color contrast photograph to detect these lesions were less than 95%. So, coming to the mean diameter. Color fundus photography did show lesser mean diameter of ellipsoid area when compared to the multicolor imaging. Among the various multicolor imaging, the blue reflectance imaging did show a maximum diameter area of macular degradation. So, of course, this I have already discussed. Yes. So, discussion multicolor imaging using multicolor imaging had a better sensitivity and specificity to identify the various macular telangiectatic lesions as compared to the color fundus imaging, and multicolor imaging was better than color fundus photography in delineating the ellipse and picking up the larger area of lesion as compared to color fundus photographs. So of course we conclude by saying that multicolor imaging is an equally efficacious or in was equally efficacious in identifying the various lesions of macular telangiectasia when compared to the color fundus imaging. Thank you so much. Yes, sir. Sir, actually, it was a retrospective study. So, we didn't. Some of the images were missing, and basically, we were trying to look only for those patients who had only macular telangiectasia without any CNVM or other coexistent retinopathology. Thank you.
Can we have the next speaker, please? It will be Dr. Karobi Lahari.
What is AIOC crunch? AIOC crunch is the development of fractional retinal detachment following intravitreal anti-VEGF injections in AIOC, and it is most commonly seen in AIOC babies, which are the fulminant babies which we see in the group of AIOC. Now, what is the pathology behind this? There is an unopposed beta in the presence of VEGF suppression, so it leads to fibrovascular proliferation and accelerates the fractional retinal detachment. What happens is that once the injection is given and the time for the injection passes off, if you do not have a follow-up on these babies, they can land up with this kind of situation, which is a very, very aggressive kind of disease that a child can have. It occurs within a mean of 70 days, may occur as early as 1 week. The accelerated course differentiates it from the progression of ROP in normal course, and it may be arcuate, pre-papillary, or nasal. Now, we had a total of 106 AROP babies, and we listed it down to 10 babies who had crunch phenomenon. Now, amongst these 26 were referred from neonatologists, which they were by a national progression, and others, 27, were referred from ophthalmologists, which was as the second or the third opinion. So this was the data analysis. There were more females than males, and it was ranging maximally in the 28-weeker group. 16 were bilateral, 2 were unilateral, and the prevalence was more in the 800 to 1,000 age group. Now, in the data analysis, we found that laser was done in half and not done in half. And in the injections, the 9 patients were of ranibizumab, bevacizumab, and 7 were from ranibizumab injections. So the data analysis also showed that less than 7 days in one patient, it occurred between 1 to 4 weeks in 2, and greater than 4 to 8 weeks in 7. Now, out of the 54 AROP babies, 10 infants, that is 18 eyes, 2 were spared, all had anti-VEGF injections for battling ROP, occurred bilaterally in 8 patients and unilaterally in 2 patients. And when referred from the neonatologist versus referral from ophthalmologist, we found that it was a statistically significant figure. And this is the case series. There were two who regressed after the laser, so they were not in this fray. And the others had a combination of either laser and injections as well as surgeries in some. So only fill-in barrier was given in three children. Fill-in laser with intravitreals in 8 patients, fill-in laser with intravitreal followed by surgery in 6 patients, stage 4 surgeries in 2, stage 5 surgeries in 2, and best left clone eyes were in 2 cases. And out of the 18 eyes, we found that 13 did well and 5 did not do well, they were lost. So this is a half zone ROP, which you see in that thing. There's hardly any, this right up to the arcades. And this is another case of crunch, which you see on the right side, and the laser done. So the results is that out of 18 AROP eyes developed crunch phenomenon. On comparison of results, we found that the direct referral was more statistically, the referral from the ophthalmologist was definitely more than that from a neonatologist, and of which 18 AROP eyes with crunch phenomenon, 13 did well, that is 72.22%. Quiescence was seen in all of them, and 5 eyes did not have this. So on comparison of results of AROP with crunch phenomenon, present or absent versus status of disease quiescence was again seen to be statistically significant. There were surgical dilemmas because these were elastic, tenacious, and fibrous, multi-layered, and surgical approach was directly from the disc towards the periphery. And the prevention was the most important thing because this happened in AROP babies. So don't be fooled by apparent disease quiescence. ROP crunch mostly occurs in AROP eyes. Careful, timely close-up, and better to follow up anti-VEGFs with laser by 3 weeks or 4 weeks. Anti-VEGFs preferably avoided in advanced stage 3 or stage 4 cases. Aggressive surgical treatment recommended in all these diagnosed cases. Thank you so much for your kind attention.
That's a nice presentation, Dr. Karobi.
Thank you.
So one question. Was there a correlation between worsening of the weight or any other systemic diseases to the crunch which happened? Was it the same? Was it the same?
No, I didn't get your question. Worsening
so
of?
the baby, you're given injection, and we expect the babies who gain weight and who become systemically better, they fare well. Were these patients who had crunch? Was there a correlation that was it because of the deterioration of the systemic or its injection alone? Was there a correlation?
Yes, we had a total of 106 eyes, that is 54 babies, out of which there were only 20 who had landed up with crunch. Now, these came in different time zones, means when they were referred as a second and third referral, by that time the child was a little older because they were seen by an ophthalmologist, given the injections over there, landed up with crunch, and then they were sent. So the thing is that the time frame was a little different. By that time, the child was not in the NICU, the child was out of the NICU at home. So there was no involvement of any kind of systemic problems at that point of time when we did see these children. And the ones from the neonatologists were ones which I followed up from 3 weeks onwards. So those were the children.
That's
who
what
were
I meant.
Treated
if you
for
had
systemic.
included only primary referrals, it would have given, because when the patients are referred from outside, you might miss out on that. During that 1 month was there a stormy period which can give rise to this?
No, they were all AROP babies. So they were very stormy.
Right.
These babies, they had like a 360 zone avascular retina, and they had been given the injections maybe at 3rd week, 4th week, but on the follow-ups, probably the follow-ups were not done on time. And when the patient landed up, means you have a disease quiescence, it looks good, so the patient goes to the to the ophthalmologist. He says everything is fine, but the blood vessels have not touched the periphery. Then suddenly they go after 2 or 3 weeks, and boom, the whole thing comes up again. So that's how they were sent as the second and third reference.
Is it possible that the babies received the first treatment itself late in these cases, when they already had some amount of beyond stage 3 and excessive fibrosis?
That's what I said. Some of them were injected at advanced stage 3 also.
That could probably another contributing factor.
It could be. Yeah. We didn't get into the logistics of what somebody had done. We just got into the logistics of the crunch effect which occurred later.
The discussion can go on. Just for the want
Thank
of
you.
the time, can we have the next presenter, please? Can we have the next presenter? It will be Dr. Anubi Paharia. After her will be Dr. Praneeth Telekutta. Can I have the presentation, please?
Hello, good morning to all. I'll be presenting SDOCT based imaging biomarkers for visual prognosis in eyes with macular edema secondary to retinal vein occlusion. So, coming to the introduction part, briefly I'll be describing retinal vein occlusion is a common vascular disorder of retina and one of the most common cause of vision loss worldwide. It is the second most common cause of blindness from retinal vascular diseases after diabetic retinopathy. So, occlusion can be divided into central retinal vein occlusion or hemiretinal vein occlusion depending upon the site of occlusion. It is significant that anti-VEGF strategies involving intravitreal injections have become a part of mainstream therapies for macular edema secondary to retinal vein occlusion. There is marked decrease in macular thickness after the therapy, but there may be chances that there are no improvement in the best corrected visual acuity, which suggests that macular thickness is only one factor out of several factors which affect the BCVA. So, reason for limited visual acuity may include macular ischemia, photoreceptor dysfunction, accumulated subfoveal hard exudates, and disruption of inner retinal layers. So, SDOCT now comes into a main factor which which is a high-speed, high-resolution cross-sectional 2D image and is a powerful tool for the non-invasive assessment of retinal physiology. It also appreciates the individual layers and thus helps in the quantitatively analysis of all the layers. Despite the clinical relevance, these findings, clinicians frequently have observed that eyes with poor visual outcomes, regardless of the complete resolution of macular edema, there are certain other factors which contribute to it. So for this, we studied the SDOCT-based parameters, which included the integrity of inner retinal layers, including the inner nuclear and plexiform layer, ellipsoid zone disruption, and external limiting membrane disruption as the factors which can contribute for the decrease in not improvement of BCVA even after giving the anti-VEGF injection. So, material and method included we included the treatment naive eyes with macular edema secondary to retinal vein occlusion. This was a hospital-based prospective observational consecutive case study. The sample size was 64. There were certain inclusion and exclusion criteria. Briefly describing about the inclusion criteria, we included treatment naive RVOs who had not gone for any other treatment before and were ready to give consent and the age above 30 years. Whereas the exclusion criteria were significant media opacity, history of cataract surgeries, any other confounding retinal diseases, history of any other previous surgery or pregnancy or any intravitreal injections. Approach to the patient was history was taken in detail, systemic examination was done, ocular examination with visual acuity examination, SDOCT was done on baseline after 1 month of injection and after 4 months of injections. There were 3 consecutively anti-VEGF injections which were given. Imaging modality which included was for each eye the scan passing through the foveal center was selected along with the 3B scan immediately above and below the fovea for a total of 7 scans with a 170 micron apart and a vertical height including of 0.72 mm. The SDOCT parameters which were studied were disorganization of retinal layers, disruption of ellipsoid zone, disruption of external limiting membrane, central macular thickness, and hyperreflective foci. Coming to the discussion part, in our study, 53% had BRVO, including ST and IT BRVO. And in bivariate analysis, we could find out that the changes in the following parameters, that drill and drill size was found to be significant after the anti-VEGF injection. In multivariate analysis, the whole cohort for each study group, only change in drill size is significantly associated with change in visual acuity from baseline to 4 months post anti-VEGF. By using general linear regression formula, we found that an increase in drill size of around 90 micron is associated with reduction in 0.1 logmar in visual acuity. We did even a predictive model study which could predict that there is a significant association between predictive visual acuity and actual visual acuity. This was the chart which depicts all the parameters. And concluding for this, that there is a great extent of drill which is responsible for reduced visual acuity. This finding is explainable as disorganization represents a loss of bipolar amacrine or horizontal cells within inner retinal layers, which are important cells for transmission of visual data from photoreceptors to retinal ganglion. Further, in the predictivity model, we found that an increase in drill size of around 65 micron can predict a 0.1 logmar visual acuity at the end of 4 months. We also studied secondary outcomes like age, diabetes mellitus, hypertension, duration of hypertension, and type of hyperlipidemia, which did not come to be significant. Thank you.
Just a practical note, among all the biomarkers, which one do you think is the most significant for an ophthalmologist to see whenever monitoring any macular edema?
Sir, the most important biomarker which we see is the ISOS junction disruption basically. But if that is there, that means the visual acuity or prognosis of the disease after even injection is little poorer towards side. But in my study, the drill and drill size come to be associated with it. If there is increase in drill size, there was decrease in the logMAR visual acuity after the injection.
Thank you.
Thank you.
Yeah.
The next presenter after Dr. Praneeth will be Dr. K.R. Chakrabarti. Please be ready.
Please stick to time. Post your podium in 3 minutes, and we cannot run over into the next session.
Please start.
Yeah. Good morning, everyone. I'm Dr. Praneeth Telukunta. I will be presenting on the phenotypical variation with age in ceramide kinase like protein related. Yeah. So, I'll be presenting on the phenotypical variation with age in ceramide kinase like protein gene related retinitis pigmentosa in a single family. So we know that among the inherited retinal dystrophies, retinitis pigmentosa is the most commonest, and based on its heterogeneity, it is very complex in its phenotypical variation. The objectives of my presentation are to understand the various phenotypical presentations at different ages in circle gene related RP patients, and to differentiate these phenotypic findings from the other typical RP phenotypes. So the first case is of a 10-year-old boy who came with complaints of reduced central vision from the age of 6 years. The best corrected visual acuity was 20/80 and N10. On further history, there was no night vision or peripheral vision problems. The fundus examination showed mild arterial attenuation and central macular atrophic changes. The fundus autofluorescence showed a hyper autofluorescence ring at the macula, and the OCT showed there is loss of photoreceptors layer. So the full field ERG showed extinguished responses with reduced responses of rod cone amplitudes. So based on this, we came to a provisional diagnosis of retinitis pigmentosa with macular involvement, cone rod dystrophy, and Stargardt's dystrophy. This is a 5-generation pedigree charting showing a kind of equal affection of males and females, so showing autosomal recessive inheritance. So clinical exomic sequencing directed towards the retinal dystrophy panel was performed based on the history and the clinical findings. So we came to a diagnosis of circle gene related retinitis pigmentosa as there was a frameshift deletion of exon 7 on chromosome 2. This is the second patient who was the mother of the 10-year-old child, and she complains of decreased central vision since childhood, and on the second to third decade there was decrease in the peripheral vision as well. Her vision was hand movements, and here we can see that there is pallor of the optic disc, there is arterial attenuation, macular atrophy, bony spicule pigmentation, and also the chorioretinal atrophic changes. And the findings of fundus autofluorescence also they are going in favor of the typical RP changes. There was also loss of photoreceptors on the OCT. This is the third patient who was the nephew, and he was the first cousin of the 10-year-old child, that is the case 1. He had findings similar to the case 1. There was also one more patient, she was a 42-year-old female, and she had findings similar to case 2. So what have we seen commonly in all these patients is the macular photoreceptor affection and the severely affected full field ERG. And in younger patients, what we have seen is the mild or no disc pallor and minimal arterial attenuation. And common to older patients was the prominent vascular attenuation, total central and macular atrophy, bony spicule pigmentation, peripheral scalloped chorioretinal atrophic patches. So, in comparison to the typical RP, the circle gene associated retinitis pigmentosa shows early macular involvement, quasi-pigmentary changes, and scalloped chorioretinal atrophic patches in the later age. So, these are the take clinic messages I would like to underline. That is, a circle gene related retinitis pigmentosa shows a wide spectrum of phenotypical changes at different ages, varying from early macular involvement and quasi-pigmentary changes in the first decade to severe macular atrophy and typical RP-like changes later. And knowledge of this changing phenotype due to the circle gene from early to later part of their lives helps in appropriate diagnosis, early visual rehabilitation, and career counseling. So this present family, it highlights a crucial role of the genetic counseling and testing for future generation risk assessment. That's all for my presentation. Thank you all for the patient listening.
Very good presentation. So don't you think that the findings in the older patients were a progression of the changes over lifetime?
Yes, doctor. That is what I wanted to highlight in this case series. That at the younger age there was no severe typical presentation of RP, and this should not be confused with other dystrophies, because in this there is progression, and that would help in the future, like counseling the patient for future planning.
So I think all RPs would show progression, majority
Yeah.
of them. What differentiates your cases is the early macular involvement, whereas
Yes,
in most other RPs you will get a later macular involvement.
Yes, doctor.
Good presentation.
Thank you, doctor.
Thank you. Can I have the next presenter, please? Dr. Anubi, are you a ratified member? Because here it's mentioned anyone beyond 26065 are not ratified. Yours is 260. Oh yeah, sorry. Yeah, thank you. Sorry. Please go ahead.
My talk will be on the complications following combined pars plana vitrectomy and Ozurdex implantation. Pars plana vitrectomy is an established and safe surgical approach for the treatment of many retinal conditions. This procedure is, however, not without its complications, mostly because of postoperative inflammation. During PPV, preservative-free triamcinolone acetonide helps in reducing the incidence of postoperative inflammation. However, because of the short life of this drug, it cannot be used long-term. This is where Ozurdex comes into play. It stays in the vitreous cavity for up to 6 months, and it has a similar pharmacokinetic profile in both vitrectomized and non-vitrectomized eyes. Our study was to assess the postoperative complications associated with combined pars plana vitrectomy and intravitreal Ozurdex implantation for a variety of posterior segment pathologies. Our study is a retrospective observational study between October 2021 and May 2022. 25 patients who underwent combined PPV and Ozurdex implantation were taken up. Complications in the intra and postoperative periods up to 3 months were followed. Complications were defined as implant migration into the anterior chamber, worsening of visual acuity by 2 lines or more, increase in intraocular pressure by more than 5 millimeters of mercury from the preoperative baseline. Details of the patients were collected from the electronic medical records. These are our results. 18 of our patients were phakic, whereas 7 were pseudophakic, 2 of which had silicon SFIOL and 1 had iris claw lens. These were the indications of our surgery. Best corrected visual acuity. Preoperative vision ranged from hand movement to 6/24, and there was significant increase in visual acuity 3 months post-op. In 9 patients, intraocular pressure rose to mid-20s and was started on anti-glaucoma medications. They were well controlled, and the medication was tapered 3 months post-op. In 1 patient, the IOP raised to 30 millimeters of mercury. It was also controlled. Central retinal thickness. There was a significant decrease in central retinal thickness by 3 months post-op. However, recurrence of macular edema was noted in 6 patients. Anterior migration of the implant. This was our most important complication, and it was noticed in 2 cases, one with iris claw lens and another with SFIOL at 2 weeks and 1 month postoperatively. The implant had migrated through the pupillary space between the iris and the IOL. These are the studies that were similar to our studies. In a study done by Zheng et al., findings were similar except that they did not notice any anterior migration of implant. Study done by Kang et al., in 24 eyes studied, there were 4 anterior migration of implant, whereas in our study there was only 2. Khurana et al. Postulated that the absence of lens capsule and prior vitrectomy were risk factors associated with the anterior migration of implant. Our study is not without limitation. One is a small sample size. Second is a selection bias because patients with complicated vitreoretinal pathologies were included and there was no age and sex match controls. To conclude, combined PPV and Ozurdex implantation, even though a safe procedure in controlling both postoperative inflammation and macular edema due to various pathologies, is not without its complications. The most significant postoperative complication associated with the combined procedure was anterior migration of the implant. Thank you.
Yeah, nice presentation. So, in your own study, in your institution, was there a difference between Ozurdex injection not during vitrectomy, Ozurdex injection in SFL or AIOC patients versus combined with vitrectomy? And was there any change in the migration? What I'm asking is vitrectomy has something to do with migration versus the SFL AIOC itself is a risk factor? Was there a comparison?
No, sir, it was not compared, except that in a study done by Khurana et al., it was postulated. Because all the patients that we took were vitrectomized patients. So, if we had taken a sample size, like if we had taken controls, maybe with only Ozurdex and then with only pars plana vitrectomy, then we could have come to a conclusion.
What I'm trying to point out is the pseudophakia with PC defect itself is a risk factor.
Yes, sir.
So, in your study, what is it that you are trying to say? Like vitrectomy is a risk factor itself?
No, sir. It is because there is the absence of PC only, because of which the migration can be easier into the anterior chamber.
Thank you.
Yes, sir.
Can we have the next presenter, please?
Of symptomatic floaters. So floaters is one of the most common presenting complaint, and persistent and symptomatic floaters can cause a significant quality of life loss in the patient. So here we study the safety and efficacy of 23 gauge sutureless vitrectomy in symptomatic floaters in pseudophakic eyes. We included long-term symptomatic patients had given informed consent, and we excluded those patients who had other systemic or retinal pathologies. So the technique was a core vitrectomy with removal up to vitreous base. In those cases, PVD was not there and induction of PVD was done, and at the end, extensive search for retinal breaks was performed. There was up to an 18 months follow-up. The mean age was up to 63 years, more number of women than men, and PVD was one of the most important etiologies, and asteroid hallucis was another etiologies. So the mean visual acuity improved from 618 to 69 in our patients. So there was a good improvement in visual acuity. The quality of life survey also showed good improvement, with almost 96% patients showing satisfaction and 85% patients experiencing a complete success. 80% of our patients had completed the survey. The complications were presence of a retinal tear, but not in a patient whom PVD was induced. So retinal tear was present in a patient who had already a complete PVD, but it was an iatrogenic retinal break. So 2% had an iatrogenic retinal break. Transient complications like CME and vitreous haze were present in one eye and two eye respectively. However, both had complete resolution and a good improvement in visual acuity. None had RD post-op or end-off or choroidal detachment or hypotony. So our study, wherein we did a sutureless vitrectomy, showed a good decrease in the symptoms for the patient, that is improved quality of life. In this, we had a sutureless vitrectomy, because of which the surgical time was less, post-op inflammation was less, and hence recovery was quite rapid. So statistically significant improvement in visual acuity was present, and all our patients had initially impaired quality of life with improvement in the quality. There were low complication rates. Only one patient had retinal tear, and which was comparable, and there was no difference in retinal tear formation in those who had a PVD previously and did not have a PVD. So in all, sutureless vitrectomy in those who are symptomatic and who have been given a chance, that is, we waited for the patients for up to almost an year or so before we actually intervened surgically had a high satisfaction. There is a limit. There are limitations to this because there can be a selection bias because this was not a randomized control trial. Limited patient population, that is small size, and difficulty in determining the presence or absence of PVD. The patients in this study underwent a survey many months after the procedure, and so recall bias can be an important thing. So patients with an active lifestyle who had a poor quality of life can be considered as ideal patients. As vitreoretinal specialists, we should give them an option to undergo treatment for PVD, because we many times just ignore PVD in our OPD and tell them that come again later. Thank you.
Are you concerned? Do you counsel them about the risk of retinal detachment?
Yes. We counsel. We wait for an year before we actually intervene. We wait. We ask them don't undergo operation as a first choice. But if anyone is actually impaired too much, especially if the floater is coming in their field of vision, if their visual acuity is getting affected, then only we intervened in this case.
Thank you.
Thank you.
Can we have the next presenter, Dr. After Dr. Jitendra Singh will be Dr. Joglekar Mandar Atul. Is he here? Okay.
Good morning, everyone. I'm Dr. Jitendra Singh, Senior Resident, Medical College, Prayagraj, presenting on comparing RNFL thickness in chronic kidney disease patient and healthy controls. Study with the introduction. Chronic kidney disease is a metabolic disorder affecting the kidney and in function. OCT uses a low coherence interferometry and ability to detect any change in retinal nerve fiber thickness. Ischemia in CKD patient affect the retinal microvasculature, resulting in decrease in RNFL thickness. Thickness of RNFL vary at different stage of neuropathy. What we have concluded, we have included cases of age more than 18 having a CKD group included in group A, and age-matched control was selected from the healthy population included in group B. It is an observational study and 150 eyes were taken in each group. We included any ocular pathology, glaucoma, age-related, and any retinal pathology, history of any ocular injury, intraocular surgery, laser surgery, poor media clarity, and cooperative patient not giving consent. What we have found, we divided into two groups. 75 we have CKD, and group B age-matched control. We do not have the CKD disease. Mean age was 47.72 group A and 47.36 in group B. And out of the 75 patients, 23 males, 52 females. Majority of CKD patients were on hemodialysis. 45 patients out of the 75 patients. What we have found, through this table. Group A we have a CKD patient. Group B we have age-matched normal control. The mean RNFL thickness was studied to be thinner in group A in comparison to group B. This is a bar diagram which signifies statistically significant thickening was noted in the superior and the inferior quadrant in group A. And this is a comparison of mean average RNFL thickness between hemodialytic patient and non-hemodialytic patient in group A, and we have found that statistically significant increase in thickness was found in hemodialytic group. This is a comparison of mean RNFL thickness in various stages. Mean average RNFL thickness found to be thinnest in CKD patient stage 5, followed by 4 and 3. A discussion in present study, mean RNFL thickness was analyzed for temporal superior, nasal superior and inferior quadrant. Both the groups were compared and changes observed were statistically significant in superior and inferior quadrant. What we conclude in a study, mean average RNFL thickness was significantly thinner in CKD patient as compared to non-CKD patient. Statistically significant thinning of mean RNFL was noted in superior and inferior quadrant. A statistically significant RNFL thinning was noted in nasal quadrant with advantage age. A statistically significant thickening of average mean RNFL was noted in hemodialysis group as compared to non-hemodialysis group. A negative correlation was seen when mean average RNFL thickness was compared to duration of CKD. Thank you.
Yeah, nice presentation. Any correlation between your RNFL findings and the renal function test? Try to investigate.
No, sir. Renal function test. We have found renal function test. What patient who are categorized as
creatinine levels. Just
with the creatinine levels.
Yeah, just.
We have not matched. We have divided into two groups, CKD non-group, but not with the creatinine levels.
Thank you. Nice presentation. So, can we have Dr. After him, the last presenter will be Dr. Sumit. Dr. Sumit is here. Dr. Sumit is here.
See post. put it here. Yes, I just want to present my initial experience with the fovea sparing ILM peeling in the vitrectomy for proliferative vascular diseases. So ILM peeling in vitrectomy for proliferative vascular diseases is practiced mostly to remove the macular folds and reduce the chances of reproliferation. However, there are problems like foveal thinning, foveal drag towards the disc, and paracentral holes. So they have been highlighted in many studies. So foveal sparing ILM peeling is recommended in myopic foveosis cases in many by many authors. So can we apply the same in vascular proliferative diseases? So we did an retrospective analysis with inclusion criteria of cases undergoing vitrectomy for proliferative diseases between February 22 and June 22. All those cases underwent fovea sparing ILM peeling were included. The follow-up was less than 3 months was excluded. Cases with combined RDs were excluded. So ILM peeling technique involved curvilinear peeling, a U-turn or a circle back to avoid the foveal peeling, and doing the flap and trim. And most of the cases were done, all of the cases rather were done by the combination of two or more of these techniques. We analyzed the demographic data, analyzed the OCT images pertaining the macular thickness and foveal contour, and compared the final best corrected visual acuity at 3 months. So there are 8 cases were included, 5 males, 3 females. Mean age was 46 years. The diagnosis was PDR is most common, BRV, and one case was EELS. So we found 4 types of contours. One was well-maintained contour. One was wavy contour but well-maintained foveal depression, persistent macular edema in one case, and moderate foveal thinning. So well-maintained contour was seen in 3 cases, foveal thinning was seen in 3 cases, and macular edema was seen in 1 case. Final visual acuity is presented. Majority of the cases lie between 618 to 636. So subjective observations where the visual acuity is better preserved than generally observed with conventional cases. Foveal contour was generally well maintained, better than the observed with full ILM peelings. Problem with foveal thinning and persistent macular are still seen in fovea sparing peeling, and no specific surgical technique related complication was encountered. Thus the fovea sparing ILM peeling was generally safe as a technique. Foveal contour was maintained in many of cases. We need larger studies, larger series with comparative study to actually go ahead with this study. Thank you.
Nice presentation, Dr. Atul. What is your hypothesis?
The hypothesis is the fovea ILM is there to maintain the integrity of the fovea. The absence of ILM may lead to the foveal thinning or dragging of the foveal area. So if you let's say hypothesis is the same as what is there in myopic foveosis. It's the same hypothesis applied here.
I mean, what was your indication for ILM peeling? Like routinely you peeled ILM in
all cases having a macular folds basically, which are not removed by just simple ERM peelings.
I know, but in your cases macular hole was not there, right?
No.
So that's what is the indication for ILM peeling is what I'm asking.
Is remove the macular folds which are not removed by the removal of epiretinal membrane alone.
Okay, but the case which you showed did not have macular fold. That was a very well stained ILM with there was not even no ER.
There are some ILM folds there. Folds were there, not.
Okay, because ideally, if you want to prove that inverse peeling or the foveal peeling helps, then you need to have the study design has to be like in one group you have to peel.
Yes, agree.
Another group.
Agreed. That's what I'm telling you. It's just an initial experience. It's not a full-fledged study.
Anyways, nice presentation.
Yeah, nice presentation.
Question? This session. Thank you everyone for sticking to your time and nice presentations. Good learning. Yes, the presenters can come over on the stage. We can have a picture.